The next discussion that we're going to have is we're moving away from the heart and now going into the next system, which is the peripheral vascular system. The peripheral vascular system is basically its responsibility is to transport molecules downstream from the heart. The way it actually does this is it carries the stuff in the blood. So all the nutrients that all your cells need, okay, and all the essential molecules that your cells need have to be transported through the blood. Now, when you look at blood, it actually has two components to it. It has a liquid component, which we call plasma, and it also has the cellular component, which usually we have broken down into three major components, which is white cells, red blood cells, which is the majority of the mass, and then you have platelets. White cells, of course, are for inflammation and autoimmune correction, and as well as infection control. Red blood cells are what carries the gases, the majority of the gas, which is oxygen and some degree of CO2 transport. And then you have your platelets, very important for coagulation cascade phenomena. The plasma is the actual liquid component, which accounts for about 60% of the normal volume. Okay, 40% of the volume is actually cellular. The other 60% is actually liquid. Some material is actually dissolved fairly well in the plasma, but other stuff cannot or does not dissolve well because it's either a lipid and as a consequence has to be carried. So you can also have inside the plasma proteins and other things that will actually help carry substances so they act as carriers. If you look at red blood cells, they're specifically manufactured to carry mostly oxygen. Without adequate levels of red blood cells, you basically cannot survive. Okay? Even if you had high levels of oxygen being delivered to you, if you didn't have enough hemoglobin, the amount of dissolved oxygen is not adequate enough for survival. Okay? So really for us to survive as motion individuals walking around, we have to have red blood cells. Now, how the actual blood is doing this, how is it actually moving around, is you can think of it as a conveyor belt. Okay? In that conveyor belt, you can only put into it, in each space of that conveyor belt, so much material in it per second. Okay? If you want to put more of one material in comparison to the other, you can get it to a certain point, but after that point, you get what's called supersaturation or too high a concentration, and it cannot go any further than that. Okay? If you look at oxygen levels, that's pretty much the case. Once you hit 100% saturation, you can stuff all the rest you want into the plasma. It really does not make a difference. It's really 100% what's carried in the trucks, which is inside the red blood cells. We call that convective transport, okay, which is basically how the substances are carried between organs and are being swept along with the flow of blood. So convective transport requires that you have adequate volume of blood and that you're actually moving it at a certain rate of speed. You could put if you look at a conveyor belt, it's basically a belt where you put material into it and then it moves it downstream to the next person who works on it, usually in a factory. But if you look at a conveyor belt, it also has a limited space. You can't put too much of it. Okay? And if you don't make the conveyor belt move forward, it doesn't pass the information on to the next individual, which is what the heart basically is doing. It's got a limited volume, yes, but it also can increase the speed of the conveyor belt by increasing the cardiac output. So increasing cardiac output gives you more transfer of material a lot of times. So if you're running short on oxygen, one of the things that the body will compensate, will try to do, is it'll increase the conveyor speed. So heart rate increases as a consequence. So if you see hypoxemia, a lot of times you'll see tachycardia with it, simply by changing heart rate. It increases transport rate. Okay? So transport rate's basically flow rate times concentration of substance in the blood. And that's the way the book tries to explain it, which is fine. I try to make it more of another analogy-wise to make it more sense for most people. What are the methods for altering the rate at which a substance is carried? So you can change the blood flow rate, and you can alter the concentration. Pretty much what happens after a while, though, is you can only concentrate the material to a certain point, otherwise it'll begin to crystallize, or it begins to stick together, which is what you don't want that to do. Eventually, even as your conveyor belt is going along, in sending material downstream, the uptake is also important. You can have the body delivering plenty of oxygen to the tissue, but if it doesn't take it up, it's not doing that cell any good. Okay? That's what we call the tissue utilization rate. Okay? What kind of situation would actually lead to, let's say, high oxygen levels, but the patient would actually be very, very dead? Would be an example like somebody with cyanide toxicity. Okay? If you give somebody cyanide and you were monitoring their SVO2, the SVO2 actually begins to rise. Now, how could it be that you're giving somebody with low-grade cyanide and you're starting to get this effect? And the answer is you can see that when you're giving somebody long-term nitroprusside. Nitroprusside, when it breaks down into cyanide. So one of the things that we would monitor very closely in the ICU in that kind of situation would be an SVO2 monitoring. As soon as we saw the SVO2 rise, we would draw cyanide levels and make sure that we weren't getting into trouble, or we would shut down the nitroprusside and switch over to another agent, okay? Because that's a bad sign. Okay? Now, once the molecules arrive downstream, the only place where actually transfer is able to do this is at the capillary level. The aorta cannot transfer molecules into cells. The arterioles do not transfer molecules into cells. It has to occur at the capillary level. Okay? So it has to be a very thin membrane that allows the substances to exchange effectively. Now, the way the body does this is it has to slow down velocity. In other words, the transfer rate has to be acceptable for the worker to be able to pull it off. It'd be like watching, I'm guessing I'm showing my age, but when I was a kid, we used to watch a program called I Love Lucy. And one of the very big skits that they would do is they had a conveyor belt going, and they were making chocolates, and they increased the conveyor belt with speed, and then Lucy just is trying to pick up the chocolates and can't pick them up fast enough, even though she's got plenty of chocolates coming at her. So you have to slow down flow rate so the person has, or the cell has a capacity to uptake the molecules properly. And the place where the flow rate is at its lowest, and we'll talk about this in Chapter 8, will be in the capillaries. That's where flow rate is almost zero. Okay? So that gives you the best ability to transfer across. The other thing that also takes place, most of the time, transfer of molecules is passive. Okay? It's always down gradients. Okay? When you eat food, your food is broken down by the liver, then the liver distributes out material out in your bloodstream, and then because the concentration of, say, glucose is higher in your blood than in your cells, the glucose is uptaken by the cell. Okay, it tends to be passive. Sodium levels, all these things can occur via passive diffusion. So it's concentration dependent. Of course, because it's diffusion you're talking about, it's dependent on surface area. It's also dependent on the diffusion distance. And the permeability of the capillary wall can also be an issue for things that are not lipid-soluble. Lipid-soluble materials do not care so much about permeability of capillary walls because lipid-soluble material rapidly transfers across irrelevantly as to the actual capillary tightness. Because if you look at the brain, the example that we try to make sure to think about is that the brain itself is very tight. Its capillaries are protected by what we call the blood-brain barrier. Okay? That's actually a specialized cell called an astrocyte that covers that capillary and prevents the transfer to occur rapidly. The way we bypass it in anesthesia is we use highly lipid-soluble agents. That's how we get the medications to get into the brain quickly and put people to sleep. Many medications that you have in nature don't come that way. Instead, they come as water-soluble substances. Why? Because it's much easier to actually take a plant, crush it, okay, put water into your crushed plant material, and then get the water-soluble stuff out. It's more difficult to get the grease on the top, where the medication could be, to try to pick it up and then concentrate it, and then put it into like a pill. It doesn't work very well. So we usually take water-soluble substances and generate medicines from them, okay, until the advent of chemical industries where you actually could make more lipid-soluble agents, which is what we have nowadays. So a lipid material will pass through this like it's not even there. Okay? You also have pores in the capillary walls and certain kinds of venules as well that allows transfer water across. It's really a very small dependent of the surface area, which is about 0.01% of the surface area. And depending on which kind of organ you want, these pores can actually be larger and allowing more water passage as a consequence. The kidney's filtration system allows a lot of water transfer through the glomerulus. So what you have is, at the capillary level, you have what's called closed or continuous capillaries. These basically allow for a very tight seam, like right here seen on this actual drawing. And versus fenestrated capillaries are basically open. Okay? When you have fenestrated capillaries, the water travels through them very easily, and usually that organ is utilizing the water for something. It's either doing filtration or doing something else, so it actually allows the water to pass very easily through it. Now, fenestrated capillaries closed or continuous capillaries can become fenestrated capillaries in some situations. Sepsis or endotoxins that are released into the bloodstream can actually attack these fenestrated capillary areas, the seam areas, and make them leak. And you've all seen this in the ICU, the patient who comes in who has put on, let's say, 40 or 15 kilos on board, and it's all extracellular fluid, okay, and the person gets a hugely edematous. That's an example of somebody that's converted from a tight capillary to a fenestrated capillary. The other way of looking at this in a more visual way is that a tight capillary is by taking your two hands, putting them together, and putting your fingers together. That would be considered a tight capillary. You can pick up water with this, no problem, make a cup out of it. But a fenestrated capillary would be just take your fingers and separate them out a little bit, and now your fingers become a colander. Fluid pours through it, no problem, and that's why it goes into the interstitial space and starts producing edema in that individual. Your transcapillary fluid movement is based on Starling's law, of course. You have water-filled fluid channels that allow water movement to take place. You also have filtration, which is net fluid movement is out of the capillaries. Reabsorption is fluid movement back into the capillaries. Reabsorption a lot of times has to do with oncotic pressure, which is the number of proteins in the plasma. Your protein count is much higher in your plasma than in the interstitial space. The interstitial space under normal conditions has very low protein levels. So in other words, the actual protein is pulling back water out of the interstitial space and trying to keep it in the actual capillary and eventually into the blood component, vascular space. If you lose too much proteins, either you don't produce it from lack of nutrition, or you start losing it from certain disease processes where you don't produce enough of it, you end up having a low protein level in your bloodstream, and that person will develop peripheral edema as a consequence. Of course, reabsorption can also be taking place mostly due to oncotic pressure, but also could be from compressive forces that are on the cells. Like if you put somebody on compressive stockings, you will induce more reabsorption back into the vascular component space, as long as you don't occlude it. The factors that are important for transcapillary movement usually is hydrostatic pressure is a very important component, which means that your blood pressure that you generate is what's actually moving molecules into the interstitial space. Without hydrostatic pressure, the cells are starved of oxygen as well as starved for nutrients. Your osmotic pressure could be, of course, your sugars, but it's mostly oncotic pressure. That's the actual degree of proteins. The osmotic pressure has to do with the sugar, which is normally very tightly regulated. So osmotic pressures under normal conditions really are not significant. In other words, water goes where the salt is, okay? But it also could be from the glucose levels can also drive water out and make that person functionally dehydrated in some situations. This is Starling's hypothesis, where it shows you the net filtration rate. Okay, you can memorize this equation if you want to. I don't necessarily make you do that. Instead, I want you to think about in terms of what drives fluid across from the vascular component into the interstitial space. And the answer to that is capillary pressure will push it in, as well as the other thing that pushes it in is the interstitial oncotic pressure. So those are the two components that pull fluids into the interstitial space. You do have hydrostatic pressure sometimes in interstitial, that prevents fluid from crossing over, but that usually is pretty low, so that's usually not a factor in inhibiting fluid transfer. And the other thing that can also inhibit fluid transfer is the oncotic pressure in the capillaries, which is the proteins that are trying to pull water back in. So those are the two opposite effects. Now, just to show you what's really going on, this is what we see when you look at a capillary. But this is a really, this would be like saying a Google map and looking at it from space and saying, okay, I look at New York City, and that's really what the blood's all, that's what New York City is all about. It doesn't go down to the really close street level. Okay? What you're looking at is you're looking at a stadium. Every single red blood cell in this analogy are huge. They're equivalent to a let's say, Yankee Stadium. It's too big, and as a consequence, you really don't know what's going down here in the sense of electrolyte transfer, glucose transfer, protein transfer. All that's something that we don't really see very well. We have to sort of do experimental work to determine what's really going on. You can see the distance between the actual cell that's carrying the oxygen and the next thing, which is this is muscle tissue. You can see the striated, the sarcomeres here, the bands of them. So oxygen easily transfers rapidly across and allows for a rapid ATP production from that oxygen as being the final electron acceptor. Okay? What's interesting about this is you can see the red blood cell barely has enough space to travel through the capillary, and when the muscle contracts, what happens to the blood flow going through this? It basically stops. Okay? I'll basically take the biggest guy in the room, put a 50-pound weight, and make you hold it for, see how long you can hold it. Okay? Some people can hold it for as long as 15, 20 minutes, but after that, you're not going to be able to hold it much more than that. You're going to die. Okay? Because now your blood vessels are not getting enough oxygen into your muscle, and you're to basically it's like having a tourniquet put on your arm. So that's something we're not really made to continually contract. We're usually made to contract and let go, contract, let go. That's what we're really designed for. We're not made to continually contract and hold it forever. That's another way you can actually make people collapse really quickly. If you make them stand up and then tell them lock their knees. Okay, when they lock their knees, they basically kill the blood supply to the lower calf coming back, so blood keeps going in but doesn't come out, and the person goes unconscious usually in about 15 minutes. So in the military, they tell you make sure you bend your knees even when you're at attention. Lymphatic systems. Lymphatics basically are what empties the interstitial space. You have to empty that space eventually, otherwise it will begin to fill with proteins that will not transfer very easily back into the intravascular component. So the lymphatics are basically responsible for getting rid of all the waste products that are coming out of the cells that are going into the interstitial space, and they empty it. A lot of people think that lymphatics don't do a lot of fluid movement. They actually move as approximately 2.5 liters per day. That's a lot. Okay? So lymphatics do a very important job, and you can tell really quickly if you don't have a good set of lymphatics what happens to that person's extremity. You get what's called lymphedema that occurs. Okay? The flow of lymph is dependent on an increase in tissue interstitial pressure. So if you put a banding around that person like a sock, you will actually compress the tissue and get more lymphatic fluid drainage as a consequence. And you can also get contraction of the actual lymphatic vessels themselves to accelerate motion and moving it back to what's called the thoracic duct. It's one of the major ducts that contains lymph in the chest, and it goes into your left side of your neck. That's why we tell you not to put central line over here. You don't want to enter a needle into the lymphatics. I've seen somebody cannulate the thoracic duct, and you get this colorless white material out. Please, you got a problem at that point. If you already put a dilator into it, you need to send that person for surgery. If you do not take that person to surgery and you take it out, you put compressive forces, yes, you don't get any bleeding, but what you've done is you've damaged the lymphatic duct, the thoracic duct, and now that person will develop a huge empyema, which was their lung will fill up with lymphatic fluid. And when you put in the chest tube 3 days later, you'll see that it comes back out like milk. It's really a bad day. And that person could have a very, very bad outcome. So If you do damage it, you do get into it, make sure a surgeon's aware of it. What they'll do is they'll go in there, surgically repair it, and then hopefully it will heal and it won't scar down. But if you leave it and you break it in half, they won't be able to find its other side and they won't be able to fix it, and then you've got big problems in your hands. Again, your lymphatics are a blind end. You can see that they're really not connected up with your blood vessel directly. Instead, the interstitial space is where the absorption is taking place. And then it travels and eventually comes back in to the venous system. Lymphatics don't connect to the arteries, they connect up to the venous system. And then they drain as a consequence. So normal circulation, arterial, capillary, venule, back, heart, back to the arterial, capillary, venule, continuously going on throughout your life. This is what happens when you get what's called lymphatic damage. This is actually caused by a disease called filariasis. This is endemic to Africa and some portions of South America, but mostly Africa. That's where I've seen it. And this is somebody who's going to a missionary, goes traveling. And one of the things you got to be very careful with is you don't want to go into the water there. If you have any break in your skin, which means that if you walk barefoot into a river and you get a skin break, these actual parasites live in the water because gets into the digestive system of people, and when they don't have adequate sewage systems, they defecate in the water, and then it gets downstream. So this stuff is very nice and rich in the blood in the actual rivers. So when you break your skin, this stuff travels up your leg and attacks your lymphatic node in your groin, and it kills it. Okay? And as a consequence, it scars it, and it causes what's called elephantiasis, which is a huge swelling of the legs. I've seen this happen, even people in Western. I saw a woman that came over. She was a missionary there in Africa for several years, and then she came back. She said that she didn't know what was going on. One leg was swelling up, and we diagnosed it as being filariasis pretty quickly. And she got treatment right away to get rid of the parasite, but unfortunately the damage is already done, and the person had to be in stockings the rest of her life. So otherwise this would get worse. Eventually what will end up happening with this degree of edema is that it will start destroying the joint. Okay? And you'll get big problems with the joint. You're going to get joint replacement. So you can imagine the complications when you put a needle into this or a surgical incision into this, what's going to happen to all the fluid. It's going to pour out. Okay? Edema of any kind is in the interstitial space. I had one time, we had a rather interesting case. We were doing a total abdominoplasty. That's a big plastic surgery procedure. What they do is they make the incision all the way from the back, come all the way around the woman, come all the way to the back and back. So the only thing they don't cut is in the back, but that's the only space they have left. And then they cut out all the fat. So they take this whole section and just remove it, and then they re-stitch it back up. Okay? So it takes all the pannus off the individual. What we had done was we had put an epidural in the individual, and because the lady was a little bit heavy, it took us 2 sticks to get it in. So, but we got the epidural in, it was working just fine. Okay? And when the nurse came back the next day and took the dressing down, she called us in a panic saying that we had CSF pouring out of this individual. And I'm going, okay, all right, I'll be right there to look at what you're talking about. She says, right where the epidural spraying out.
The patient's going to die of cerebral of fluid loss. And I'm going, well, does she have any kind of problems? Like, does she have a headache? Does she have any, numbness in her legs? Because that would indicate that you would got into the spinal fluid space, and now you've got you'd be having a spinal, not an epidural. What we ended up finding was when we looked, the stick that we had initially put in was now at each site for all this edema that this woman had. So all this edema that she had from this big surgery now was pressurizing, and you can actually, we measured the distance, it was 15 centimeters of the fluid streaming out under high pressure. So we let it sit there for 15 minutes and let her drain. We drained 2.5 liters of fluid from this little hole. It's rather impressive. And she felt a lot better. The edema got a lot less. So we just let it drain. So we just acted like a little drainage hole for her. And then once the fluid stopped, then we put the dressing back on. Sure enough, 6 hours later, what did she do? She redistributed the fluid back into space and lost another 2.5 liters, which we kept doing about every 6 hours. Eventually, the hole sealed up, which was fine, but it had nothing to do with the epidural.
Okay? So these kind of things, when you make a surgical incision, you're going to have a big problem in your hands. You're going to lose a lot of volume through those incision sites. If you look at the basic vascular function, where it's all the actual workloads taking place is at the arterial level. Okay? It's not taking place at the aorta itself, which is the conducting vessel. If you want to change resistance, you really are doing that at the arterial level. There's no changes, there's no muscles in the capillaries, so you really can't change resistance. And so what actually looking at for your basic flow equation is your change in pressure over resistance. And ultimately, blood flow is based on volume over time. And depending on which system you're using, if you're looking at the pulmonary circulation, it's a system in series. But the actual system for your systemic circulation is in parallel. So there's different kinds of equations. I'm not going to go into that. I think it's kind of foolish. It's just, it's basic physics. But do you really need to know that? The answer is really not. You just have to understand that there's two different systems. Pulmonary circulation is in series, and the one that can alter significantly resistance is out in systemic vascular resistance, where you actually cut off blood flow completely to one organ in basically trying to support another organ and keep it alive. If you look at your peripheral blood flow velocities, your blood flow velocities drop off dramatically at the arterial level, and the flow is at its lowest at the capillary level. During the aorta, the flow velocity is actually so high that all flow in the aorta, or the conductance vessels, is considered turbulent. Okay? Blood velocity can be measured as distance over time. Okay? And the lowest blood velocity is at the capillaries, which is going to be a test question, so make sure you know that one. Okay? And the next place where it begins to accelerate is in the venules and veins, actually have higher velocities than capillaries. Most people somehow think that veins and venules have lower velocities than the capillaries, but they don't. The reason they don't is the surface area in comparison to capillaries begin to decrease. So as a consequence, you're taking a lake and trying to compress it through little arteries, through little veins and venules, which are your surface area is decreasing, so you're accelerating the fluid volume as a consequence. This is what I expect you to memorize for your test. You should have this in your mind, even when you're taking care of people clinically. You should know flow. Okay, first of all, is the first graph. Flow velocity is broken into, and all these graphs are broken down into 4 compartments: conductance, resistance, transference, and capacitance vessels, which is basically arteries, which is the conductance vessels, arterioles, which is resistance vessels, capillaries is the where the exchange is taking place, and the veins and venules, which is the capacity area. Okay? You can see the flow velocity is fairly steady in the aorta and the femoral arteries and, say, the subclavian artery. The arterial velocity is still very high, but then when it gets into the arterial level, which is usually at the hand or wherever you get into, start getting into tissue, arterioles vasoconstrict, and it can cause a dramatic drop in flow velocity. Okay? So flow velocity is really the greatest change of flow velocity is at the arterial level. By the time you get arterial, it gets into the capillaries where flow velocity is at its lowest, at around 0.5 millimeters per second. That's very, very slow. And then you can see the velocity begins to re-increase in the veins and venules. The next graph that you need to look at is this one. That has to do with blood volume. Only around 12% of your blood volume is in your conductance vessels. 2% of your blood volume is in your resistance vessels, which are arterioles. And your actual capillaries, because they have a greater surface tension, surface area, they have approximately 5% of the volume. But by far, the majority of the blood volume, which is 80% of the blood volume, is in the venules and veins. Make sure you know that as well. Okay, volume is not in your arteries. Volume is in your veins and venules. The next thing, pressures. Okay, trick up. Okay, pressure is not the same thing as flow. Flow is a movement of molecules per second. Pressure is just this millimeter change in mercury. Period. the pressure inside your aorta is greater than the arterial, greater than the capillary, greater than the veins. In other words, the pressure in your veins is the lowest pressure, but still velocity is faster in the veins than in the capillaries. So make sure you sort of understand that. Okay? Do not get fooled by the terminology. If I ask you pressure, I'm referring to this third graph that's just looking at pressure differences. If we look at the mean in the aorta is pretty much constant. Once you get into the arterial, mean pressure begins to fall. Still, the capillary pressure, mean pressure, is higher than in the vein system. It kind of makes sense. If you look at a Starling's law, what do we talk about? What's the major thing that moves molecules across? It's pressure. Okay? So hydrostatic pressure. So it kind of makes sense that you would have a higher capillary pressure, but you would have a lower flow. Okay, that's kind of nice. But your veins have the lowest pressure. Now, the other thing that you'll see in this graphic representation here, see down. I want you to,
If you look at the aorta from the heart, where it pumps out blood, and you go further downstream, let's say down to the radial artery, okay, which is further down. The further you go away from the aorta, the mean arterial pressure is the same. You can see this line is basically the same. But as you go further and further away, the systolic pressure gets higher, and the diastolic pressure gets lower. Why is that important? Well, because you can't change physics. And because you can't change physics, you take somebody's blood pressure cuff up here, and then you take an A line down here, that the numbers will be the same. The only thing that will be the same will be what? The mean. The mean arterial pressure is identically the same. When you work in an ICU, invariably will happen is somebody will pick up the phone and call the doctor, or usually the anesthesiologist, we put all the lines in, and we'll get a phone call telling us, hey, you know, you're going to be CRNAs eventually, so you'll get a phone call from the ICU and they'll be telling you, look, you have an A-line that doesn't work. The first question you got to ask is, what does it mean? And they tell you, well, the mean's 60. What's the non-invasive blood pressure mean? It's 60. Okay. So the first thing you already know is that the A-line's working. You do. Okay, the mean's the same. Now, if the mean was lower, then you have a problem. Could be there's a clot inside the line. Could be there's air in the line. There's something that's dampening it. Okay, but if your mean's the same, what they're seeing is that what they're not liking is that they're seeing the amplitude is different than the non-invasive blood pressure cuff. Then the next question I ask is, what's the blood pressure cuff saying in the arm, in the upper arm? And they say, well, it's measuring 140 over 80. And I said, what's the A-line going to measure? And my answer in the top of my head would be, it should be 160 over 60. And sure enough, I get the answer back, it's 160 over 60, and we don't like the systolic pressure, it's too high. And I said, well, you should be really treating it the mean, okay, because I cannot change that. And I can come in the room and look at it, but it's not going to make a difference. The actual arterial waveform down here is going to generate a greater systolic, but a lower diastolic. And whatever the difference between the two, height-wise, if it's 20 above, it should be 20 below. Okay, that's why I said if it's 140 over 80, it should be 160 over 60. That's what you should expect. Okay? Now, if you put a femoral A-line in, down here, the femoral A-line is a little bit closer to the aorta, so sometimes that gives you a much better waveform, more like the aorta. Okay, so some people like that waveform better, especially if you put the long catheter in, which is you put in the 20-gauge catheter, which is really long, okay, which is about that long. So now you're up here in almost the femoral artery, almost in the iliac artery, so you're pretty close to the aorta. That's going to correlate a lot more closely to a non-invasive blood pressure cuff than a radial A-line. Okay, but if you go down to the dorsalis pedis down here, or the posterior tibial, and measure the A-line there, what's going to happen to your systolic and diastolic pressure? That's further and further away from the heart, so my systolic pressure should be greater in my foot
But my diastolic pressure will also be lower in my foot than in the A line up here. Okay? They will ask you that in the C exam. I will ask you that on the test to make sure you understand that concept. Okay? And the last graph is basically indicating to you where resistance is taking place. Resistance is always taking place in the arterial, period. It's not taking place in the capillaries or minimally. It's not really taking place in the conductance vessels. All resistance is regulated at the arterial level, which is why it's a big hump here. If you look at peripheral blood volume, 20% of the total volume is actually found in the heart and pulmonary circulation. And you can break this up into two components. We call it the peripheral venous pool and the central venous pool. Okay? The peripheral venous pool is where most of the blood volume is located at. It's found in the venous capacitance and systemic organs. Okay? The central venous pool, I'm not sure I consider this. Book says it's second importance. I think what they should have said, it's not importance, but it's the second in volume. Okay? Because central venous volume is actually the most important to me. That's the volume that heart can actually take in. That's what is actually going to become the preload. So if I decrease central compartment venous volume, my preload is going to suffer. So to me, that's more important. So the book says it's the second. It should be, I think it's a typo. I think it should say second in volume. Okay? It contains the great veins of the thorax and the right atrium. So superior vena cava, inferior vena cava, and the right atrium are all considered part of the central venous pool. That's not a large amount of area if you think about it. So it's really not a large volume, but that's really what the heart has to work with in between and diastole to try to get that volume back into the ventricles. Increasing a central venous pool volume ultimately will give you a greater preload. If, on the other hand, you compress that area and cause the volume to drop, even though the pressure may be higher, that person has a lower preload. So even though measurements is usually done with preload, you also have to take into consideration, am I giving this person positive pressure ventilation, and is it affecting my pressure curve, which it is. When I put a person under positive pressure ventilation, and I begin to ventilate them with a ventilator, I'm squeezing the lung from inside and pushing on the heart. Every time the ventilator fires, it causes positive pressure in the chest. And during that pressure phase, the heart is being compressed, as well as superior and inferior vena cava, and preload drops. If you give too much volume, you can cause so much problems that the blood pressure drops acutely every time the heart cycles, okay, which is not something you want to see. If that's occurring, you're actually giving that person too much volume or too much pressure. Okay. Peripheral blood pressure is regulated mostly by the arterioles. Okay? If you go from the large arteries, this is what I was talking about before, the systolic pressure gets higher. Mean arterial pressure stays the same, and the diastolic pressure gets lower away from the heart. The way I just do this figuratively, where I think about it, is I just take a cone and just go like this. Okay? So here's my person generating the pressure waveform, and even you're generating a pressure wave as you go further and further away. So this would be my foot. This would be my hand, or my wrist, in other words.
This would be my aorta. Okay. Notice about every single one of these, the same thing means the same. But the further and further away you go from the heart, the greater the systolic pressure is, and the lower the diastolic pressure. Okay. Where you see where all this stuff begins to drop off, we don't put A lines in arterioles, right? Where do we put the A lines at? They're in conductance vessels. Okay, so this applies only to conductance vessels. If you go back to this graph, what happens to when you're in arterioles? Look at what happens to actual pressures. They'll never ask you that, but if somebody for some crazy reason says to you, what happens in the arterial, what happens to the mean arterial pressure in arterioles? They drop dramatically. As soon as the resistance takes place, mean arterial pressure falls.
Okay, but we don't monitor there. We don't put a catheter into an arteriole. At least I've never seen it done. I mean, I'm sure they can do it in a lab, but I've never seen it in clinical. So it is the resistance vessels, and when you look at after the arterial, pulsatile pressure disappears. So remember I talked to you about this before. I talked to you about how organs that are, when you go on cardiopulmonary bypass, the pulsatile effect is important. Well, most likely the control mechanism is at the arterioles. It's not at the capillary level, because the capillary doesn't see any pulsatile pressure. It sees a mean pressure that's constant. Okay, it does not see pulsations. And that's kind of important if you think about it. If you see pulsations, what does that do? Transmits energy. Okay? It would be like taking this door and opening it and closing it all the time. Okay? If it's got good hinges, not a problem. But imagine that you made paper hinges, which is what a capillary is. Okay? Just keep doing that. What's going to happen eventually to that hinge? It's going to rip. Okay? So it's going to break, and that would be bad. So you don't want pulsatile flow ever to get into a capillary because it's thin-walled and it'll tear. Okay? So that's something you don't want to see. Capillaries have an average pressure of around 25 millimeters of mercury, so that's much greater than your veins. Okay, what's your measurement on your V turn usually in your CVP? 5. Okay, so that's much lower than this. Okay, but capillaries are higher pressure at 25. Capillary, even though it's thin membrane, it can tolerate pressure, but it cannot tolerate shear. It cannot tolerate pulsations. And it cannot tolerate flow. So flow velocity is very low, and pulsations disappear. If you look at your peripheral vascular resistance, it's all taking place at the arterioles. That's your large resistance to flow. Blood flow through an organ is primarily regulated by the adjustment of the internal diameter of the arterioles. You cannot change the length of an arteriole unless you do it for long term, like say if somebody's becoming morbidly obese or something like that. But under normal circumstances, length does not change. It's radius that's being changed. Okay, and that's caused by muscular contraction by the smooth muscle that's inside that blood vessel. And we'll talk about this next week when we talk about how regulation is taking place. I'm going to go into more detail about what regulates arterial vasoconstriction. Basically, arterioles act like dams, and they slow velocity down tremendously. This is a blow-up of showing you what happens to pressure. This is not flow. This is pressure. You see that once you get to the arterioles, the pressures drop dramatically, and then you go down to basically non-pulsatile flow, where you have your mean arterial pressure stays constant, usually around 25 in capillaries, and continues to fall as you get back to the central compartment. One of the things that it's important to understand is that your basic vascular function is dependent on the elastic properties of arteries and veins. Arterioles tend to be changing. They change with age. When you're younger, your arteriole is able to give more. So as a consequence, a little kid has a lower blood pressure than a person that is older. Okay? As you get older, your arterioles become stiffer and stiffer, which means that for the same amount of volume that you're delivering it, you generate a greater pressure. Okay, so normally as you age, your pressure should go up. But that's been found not to be true unless you're in Western society. If you were to live out in the jungle, say, and you were exercising every day, climbing a 50-foot tree every day, and you're exercising tremendously, your arterioles actually stay as pliable as they do when they're 20 years of age. Okay, so doing high-intensity exercise basically prevents this disease process from taking place. But if you're sedentary like most of us, or you're sitting around the operating room for too many hours watching a screen, and all you're doing is standing, and you don't really have any way of exercising quickly, then you eventually will develop hardening of the arteries, and your compliance will become less compliant. So you will develop a higher incidence of hypertension. So people that are white-collar workers that don't do any exercise have a higher incidence of hypertension than people that are blue-collar workers doing a lot of heavy-duty work. Okay, so there's some benefits to being blue-collar in a sense. Okay? Also, the downside to it, of course, is blue-collar workers die higher incidence of injuries, okay, than white-collar workers. Anyways, you're looking at venous elasticity. Venous system is much more elastic. It's able to give more, so it acts as a capacitance vessels. They're much more compliant than the arterioles. The arterial elastance allows for the development of diastolic pressure, which is important. If you didn't have the arterial elastance component, which is squeezing down, back down, your diastolic pressure would go to zero. Okay? The downside, as your arteries become more rigid, what happens to your diastolic pressure in between? It goes down. So even though you're hypertensive, your diastolic pressure doesn't go up with it a lot of times. Your diastolic pressure stays lower. So there's a higher workload on the heart, but during your diastolic phase, the pressure drops very quickly. Okay, so if you had rigid tubes, you could not store potential energy, and then diastolic pressure would actually go to zero. This is a classic example of what happens here. This is your veins, high capacitance, so it allows for volume to go in without very much change in pressure. So volume can change very easily. This is an arterial here. This is what the arteries do. They have a limited accepting of volume with a tremendous increase in pressure. Now, I don't know if I did the next one, but let's say this is a normal individual. I'm going to do the same thing, but I'm going to show you the normal individual. Let's say he's young. He's right here. Let's say this is his arterial. So for the same amount of volume, let's say we change the volume, let's say by 50 cc's or something like that, you're going to get a significant change in pressure. Okay? But as you get older, this line shifts. It goes up like this. Okay? So for the same amount of volume, this person is going to change, say, the same delta P. I didn't draw this properly. Okay? For the same volume change, now that person is going to generate a greater pressure now. Okay? So you see there's going to be a greater pressure in comparison to here. And that's bad. That leads to hypertension and other disease processes. Last thing, and then we'll stop for 10 minutes, is determinants of mean arterial pressure. I think you do have to memorize these two equations. This will be on the test. There's two ways of measuring mean arterial pressure. One is cardiac output times total peripheral resistance, or systemic vascular resistance. And the other way of measuring mean arterial pressure, which is what we tend to do, which is diastolic pressure plus 1/3 the systolic pressure minus the diastolic pressure. Okay? That's the way I expect you to know both these equations when you think about mean arterial pressure.